So already we have seen about this. You can see already we have discussed about this, how the parathyroid gland secrete the parathyroid hormones, and this parathyroid hormone, calcium and vitamin D ultimately orchestrate a balance so that there will be calcium and vitamin D will be available in the serum in the normal level. So you can see 4 parathyroid glands. In the previous class we have discussed, from the 4 parathyroid glands parathyroid hormone is secreted, and this parathyroid hormone acts on the kidney, it acts on the bone. In the kidney it decreases the urinary calcium secretion. More portion of the urinary calcium is absorbed back, but urinary phosphate secretion is increased by means of the parathyroid hormone, and it also acts on the bones. In the bones, ultimately it helps in the resorption of the bones, so more plasma calcium will be available from the bones to the plasma, and ultimately there will be also calcitriol. Calcitriol is the active form of the vitamin D. In the previous class we have discussed how vitamin D is synthesized from the skin, how there is 1 alpha hydroxylation and 25 alpha hydroxylation, and 125 dihydroxy vitamin D is formed. And this calcitriol is also acts on the bones, and it helps in maintaining the balance in the plasma as well as in the bones. And in the intestine also, this calcitriol and parathyroid hormone acts on the calcitriol to increase the calcium absorption from the intestine and increase the phosphate absorption. So from this you can see that both the calcium absorption as well as the reabsorption in the kidney as well as the intestine are increased by the parathyroid hormone as well as the calcitriol. But in case of the phosphate, parathyroid hormone increases the secretion of the phosphate in the urine, while the calcitriol or the active form of the vitamin D mainly retains the phosphate. Only there is difference in the phosphate reabsorption, the action between the parathyroid hormone and calcitriol. Otherwise, parathyroid hormone mainly helps in the calcitriol in maintaining the balance of the calcium. The same thing you can see when there is plasma calcium is decreased, when there is hypocalcemia. Already we have seen the normal level of the serum calcium 8.4 to 10.5. If it is less than that, so there will be increased parathyroid hormone secretion. So parathyroid glands are present posterior to the thyroid gland. From this the parathyroid hormone is secreted, and this increased parathyroid hormone in the previous pictures already we have seen that in the one hand that causes increased bone resorption, in the other hand it causes decreased renal tubular reabsorption of the phosphate and increased renal tubular reabsorption of the calcium, and it happens by increasing the formation of the active form of the vitamin D in the kidney. So ultimately parathyroid hormone acts on the intestine, it acts on the kidney, it acts on the bones. What is the action of the parathyroid hormone on the intestine? In the intestine, it helps in increased absorption of the calcium as well as the increased absorption of the calcitriol, and this calcitriol in turn also helps in increased absorption of the calcium. Okay. In the kidney, parathyroid hormone helps in increased reabsorption of the calcium, but it causes less reabsorption of the phosphate and more secretion of the phosphate. And in the bones, it helps in the resorption of the bones so that more calcium will be available in the serum or in the plasma. So when there is balance is disbalanced, there will be more parathyroid hormone secretion, but when the balance is maintained, the parathyroid hormone secretion will be less. Okay. So this way the balance is maintained, the homeostasis of the calcium, vitamin D and parathyroid hormone is maintained. So now coming to the calcitonin. So calcitonin is another hormone that is related to this calcium, vitamin D absorption and balance. Parathyroid hormone is secreted from the parathyroid gland that is present posterior to the thyroid gland, but this calcitonin is secreted from the thyroid gland itself. So it is secreted from which cell of the thyroid gland? Parafollicular cells or C cells of the thyroid gland. So within the thyroid there are parafollicular cells or C cells, and from these parafollicular cells or C cells this calcitonin is secreted, and these cells are lying in the interstitial fluid between the follicles of the thyroid gland. So basically this is a 32 amino acid single chain polypeptide. It is a polypeptide with a disulfide bridge between position 1 and 7 and molecular weight approximately 3400. So it ultimately tends to decrease the plasma calcium. So more or less in nutshell you can say the action of the calcitonin is just opposite of the parathyroid hormone. So parathyroid hormone always tends to increase the plasma calcium level. How it tends to increase? Time and again I am discussing. It increases by causing the increased resorption of the bone. It causes the increased absorption of the calcium. It causes increased reabsorption of the calcium, increased activation of the calcitriol. But the calcitonin is the hormone that mainly causes decrease the plasma calcium concentration, and in general they has effects opposite to that of the parathyroid hormones. So it is the most potent peptide inhibitor of the osteoclast mediated bone resorption, and it helps to protect the skeleton during periods of the calcium stress. Calcium stress means when the calcium level is less. Okay. So ultimately when there is problems, when there is more calcium is present, they tends to decrease the plasma calcium concentration. So you can say synthesis and secretion of the calcitonin is regulated by the plasma calcium concentration. Again, usually when the plasma concentration, again it becomes disbalanced, the calcitonin level rises. Rise in plasma calcium increases the calcitonin level, and fall in plasma calcium decreases the calcitonin level. Just remember the opposite actions of the parathyroid hormone, the actions of the calcitonin. Circulating levels of the calcitonin is low, and its physiological role in regulating plasma calcium appears to be minor. So only the actions of the calcitonin becomes florid when there is severe hypercalcemia. When there is very high calcium level, then the calcitonin secretion becomes more. Otherwise the secretion of the calcitonin is minute amount. The plasma half-life of the calcitonin is 10 minutes, but its action lasts for several hours. It decreases plasma calcium concentration rapidly within minutes after injection of the calcitonin. So the actions, it inhibits the bone resorption by direct action on the osteoclast. Osteoclast cells, it inhibits the bone resorption by direct action on the osteoclast. It inhibits the proximal tubular reabsorption of the calcium and phosphate by direct action on the kidney. Inhibits the reabsorption means more calcium and more phosphate will be secreted out through the urine. Action is mediated to G-protein-coupled receptor and increased CMP formation, but target cells are different from the parathyroid hormone. The actions are just opposite of the parathyroid hormone, but the targets are different. Parathyroid hormones act on the parathyroid receptors, but calcitonin acts on separate receptors. So you can say this is a type of the physiological antagonism. You have read about the different types of the antagonism. So the physiological actions are opposite to one another, but the actions by which it is mediated are different in parathyroid hormone as well as the calcitonin. So you can see this is the mechanism of actions of the calcitonin. This is the thyroid cells. Within the thyroid cells, within the interstitium, there are parafollicular or C cells, and from this the calcitonin is secreted. It acts on the calcitonin receptor, binds with this, and ultimately it prevents the resorption of the bone. So direct inhibition of the osteoclastic activity, decreased bone resorption and decreased release of the calcium phosphate into the blood happens due to the calcitonin. So preparation calcitonin is mainly available from the salmon fish. Salmon calcitonin is available most commonly as treatment. It is antigenic, so some hypersensitivity reactions may develop. Synthetic salmon calcitonin is more potent and longer acting due to slower metabolism. Synthetic human calcitonin is 1 international unit equivalent to 4 microgram of the standard preparation. Mainly this can be given in the subcutaneous, intramuscular or intranasal spray. Usually calcitonin can be given 200 units intranasal spray. So if you are asked one example of the hormone that can be given by intranasal spray, this is a salmon calcitonin. Salmon calcitonin intranasal spray is available. 200 international unit usually is given, but when it is given in the subcutaneous or intramuscular route, the dose is usually lesser, usually 100 international unit. Now where we have to use the calcitonin? First is in case of the different types of the hypercalcemic states. Since their actions is to decrease the calcium level in the blood by decreasing the resorption of the bone, mainly it is used in different types of the hypercalcemic states. Now what are these hypercalcemic states? Hyperparathyroidism. Already in the previous class we have discussed the hyperparathyroidism. Hyperparathyroidism means there may be some parathyroid adenoma or parathyroid tumor or carcinoma from which more parathyroid hormone is secreted. When more parathyroid hormone is secreted, already we have seen there will be more calcium absorption, more calcium reabsorption, there will be more calcium availability in the blood, so there will be hypercalcemia. If there is some hypervitaminosis D, again we have seen, if there is some inadvertent use of the vitamin D in excess of what we need, there will be hypervitaminosis D. That will also lead to hypercalcemia. Osteolytic bone metastasis, this is the most common where we have to use the calcitonin. So when there is some cancer and this cancer ultimately metastasizes to the bone, there will be some osteolytic bony metastasis. The bones will be more broken, there will be more resorption of the bone and more calcium will be available in the blood. So osteolytic bone metastasis and hypercalcemia of the malignancy. In different types of the cancer is also the calcium level is rises because the cell growth will be more. When the cell growth will be aberrant, abnormal cell growth, there will be more calcium available within the plasma. So all this leads to hypercalcemia. So hypercalcemia most commonly seen when there is some types of the osteolytic bony metastasis, that is cancer is elsewhere, that cancer have spread to the bones and ultimately that leads to osteolysis, breakage of the bones. Then there is different types of the metastasis to the bones, hypercalcemia of the malignancy, and in some cases if there is some parathyroid adenoma, parathyroid carcinoma, that can lead to parathyroidism. So in these cases we have to use the calcitonin. Usually the salmon calcitonin nasal spray is used. If it is not responding, we can give the subcutaneous or intramuscular route. It acts rapidly within 4 hours, the response peaks at 48 hours and then refractoriness develops. So it also relieves the bone pain. Severe bone pain usually happens due to osteolytic bony metastasis. Again, another is the Paget's disease of the bone. Paget's disease is basically a disorder of the increased skeletal remodeling. So there will be continuous skeletal remodeling, osteoclastic bone resorption followed by osteoblastic bone formation. So in resorption and formation of the bone, this goes in a cyclic fashion. This is known as the bone remodeling. Bone modeling, only bone modeling means bone growth. But usually in our body, the bones, the abnormal bones, the damaged bones are removed by means of the osteoclast cells. And then removal is again supplemented by the osteoblastic bone synthesis. And these osteoblast and osteoclast cells, they are mainly regulated by the osteocyte cells. All this you have read in the anatomy and the physiology. So osteocyte regulates the osteoblastic bone formation and osteoclastic bone resorption. And this osteoblast, osteoclast, how much amount of the bone will be resorbed and how much amount of the bone will be again regrown, this ultimately depends upon on the calcium level, vitamin D level, parathyroid hormone level. Usually in our normal persons, there will be a balance between the bone resorption and bone formation. So the amount of the bone that is resorbed, the same amount of the bone will be again regrown by means of the osteoblastic bone formation. So it is clear. So osteoporosis when happens? When there will be a disbalance between this osteoblastic bone formation and osteoclastic bone resorption. That means either there will be more resorption of the bones, there will be more bone breakage, but bone growth will not be at the same par with that of the bone resorption. So there will be less bone mass formation, so there will be osteoporosis. Otherwise, there will be normal bone resorption, but the bone growth is not normal. So bone growth will be less, osteoblastic bone formation will be less. So if there is disbalance between the bone resorption and bone formation, there will be osteoporosis. That is the micro architecture of the bones will be less, bone mineral density will be less, so that the bones become more fragile. With minor trauma, there will be some breakage of the bones, there will be fracture. So this is the osteoporosis, and this osteoporosis becomes more when in case of the elderly age group and in case of the postmenopausal women. Okay. So that's why Paget's disease of the bone is basically a disorder of the increased skeletal remodeling. So this is another disease where there is increased skeletal remodeling happens. So after improvement for few months, later resistance may develop due to production of antibodies. Osteoporosis, different types of the osteoporosis, most commonly postmenopausal osteoporosis, and also in the previous class I have said that due to some drugs or due to some other diseases, osteoporosis can also develop. These are the secondary osteoporosis. The most common drug that can cause osteoporosis is the corticosteroids. Since corticosteroids are utilized in different types of the diseases, In some diseases, we have to use the corticosteroids for a long period of time. In those cases, the patients will be more vulnerable for the osteoporosis. So, corticosteroid-induced osteoporosis also we have to use the calcitonin. In the osteoporosis, already I have discussed how the osteoporosis happens, and diagnosis of the medullary carcinoma of the thyroid, details is not required. So, remember, even if the actions of the calcitonin is just the opposite of the parathyroid hormone, both the parathyroid hormone analogues as well as the calcitonin analogues, both are used for the management of the osteoporosis. Okay, so adverse effects, usually there may be some flushing, tingling sensation in fingers, altered taste, etc. Flu-like symptoms, allergic symptoms, etc. can happen. Otherwise, the adverse effects are not so florid. Fibroblast growth factor 23. So basically, this is also a growth factor that helps in the fibroblast to grow. It is a protein of 251 amino acids. Primarily, it is produced by the different types of the bone cells like osteoblasts, osteocytes, etc. in response to dietary phosphate load. So if there is some deficiency of the phosphate, so there will be less this fibroblast growth factor 23. So again there will be some problems in the bone formation. So main function is the promotion of the urinary phosphate excretion and the suppression of the active vitamin D production by the kidney. So mainly this fibroblast growth factor helps in this. Klotho is basically a membrane protein that serves as an essential cofactor in the transduction of this fibroblast growth factor 23. So it has been seen that if we are exogenously administered this fibroblast growth factor 23, that can reduce the serum phosphate excretion and calcitriol synthesis. So ultimately, no significant drugs have been invented till now on the fibroblast growth factor 23, but remember in the future some drugs can be invented on the basis of the fibroblast growth factor 23 that mainly targets the phosphate load and also again maintains the bone architecture. Now coming to the bisphosphonates. This bisphosphonates is very important for the management of the osteoporosis, and now this is the first line therapy for the management of the osteoporosis. So we have, if a patient is diagnosed with, for example, this is very common, elderly osteoporosis or postmenopausal osteoporosis, first we have to give the bisphosphonates, along with we have to supplement with the calcium and vitamin D. So what are the bisphosphonates? They are the non-hormonal agents in the calcium homeostasis. They mainly forms a three-dimensional structure capable of chelating divalent cations such as calcium and have a strong affinity for bone, targeting especially the bone surfaces undergoing remodeling. So basically within the bones there are pyrophosphates, they resemble the pyrophosphate. So when we are giving the bisphosphonates, they ultimately attaches with the bones and helps in the bone remodeling. So they prevents osteoporosis and helps in metabolic bone disease and hypercalcemia. This is the most effective anti-resorptive agent at present. So this is the structure of the bisphosphonate. It is the analog of the pyrophosphate. This is the pyrophosphate and this is the analog of the pyrophosphate, which is the bisphosphonate. So there will be side chains. You can see R1 and R2. So there are different types of the side chains we can add to this, and different bisphosphonate molecules can we obtain. So they are basically attached to a geminal or central carbon. So this is a central carbon or geminal carbon that replaces the oxygen in the pyrophosphate. So within the pyrophosphate there is oxygen in the central position. This oxygen is replaced with a carbon, and within this carbon different side chains are added. This R1 side chain is basically affects the binding affinity to bone. So if we changes the R1, so different bisphosphonates have different binding capacity to the bone. R2, another side chain that affects the anti-resorptive capacity, that how much it helps in the resorption of the bones. Anti-resorption, that it interferes with the resorption of the bones, depends on which is supplemented in this R2 position, and possibly this is also related to the side effect profile. So they have different potency. There are first generation, second generation, third generation, etc. So you can see that with successive generation there will be increased potency of the bisphosphonate. That is, there will be more active binding with the bones and the more interference with the bone resorption. So you can see first generation which have simpler side chains like etidronate, tulidronate. Etidronate and tulidronate relative potency, if we can say that etidronate, the first one of the relative potency is 1, tulidronate is 10 times of this. The second generation, there will be some amino or nitrogenous side chains like Pamidronate, Alendronate and Ibadronate. So Pamidronate, Alendronate, Ibadronate, you can see the relative potency increased more than 100 to 1000 times that of the etidronate. So these are the more potent bisphosphonates rather than the first generation ones. The third generation example is the Remodeling and Zoledronate. Remodeling approximately 1000 times more potent than the first generation one, and the Zoledronate is the most potent one, approximately 5000 times more potent. Okay. So these are the examples of the different bisphosphonates. Etidronate, Telludronate, Pamidronate, Alendronate, Ibadronate, Remodeling and Zoledronate. Zoledronate or zoledronic acid, the same thing. So the first generation bisphosphonates contain minimally modified side chains or possess some chlorphenol groups. That is, they are more or less similar to that of the pyrophosphates except the geminal carbon supplementation. Second generation ones contain usually a nitrogen group in the side chains, 10 to 100 times more potent, already you have seen. And the third generation contain a nitrogen atom with a heterocyclic ring and up to 5000 and some cases 10,000 times more potent. Okay. So the mechanism of actions, they have selective affinity for the calcium phosphate. So calcified tissues and direct inhibitory effect on osteoclasts. So I have said that they are similar to pyrophosphate. So since they are similar to pyrophosphate, so they have similar affinity to attach with the bones. This is the first one. So usually there are two components of the bone. You know, one is the bone matrix, another is the solid mineral phase. The solid mineral phase is formed of hydroxyapatite. Now normally this non-mineralized osteoid covers the mineralized bone matrix, preventing its resorption by osteoclast. Usually there will be some coverance on the osteoclast cells. When the resorption is needed, there will be uncovering of this. For resorption, osteoids must get dissolved and mineralized or solubilized such that osteoblasts can attach to the mineralized matrix. So this is basically a cycle how the resorption of the bone happens. These osteoclast cells are mainly activated by the osteoblast cells, and these osteoclast cells ultimately get dissolved on the mineralized matrix so that they come into contact with the mineralized ones, and then they helps in the resorption of the bone. And this resorption of the bones mainly happens in the resorptive pits. So there will be some crescent like formation is developed within these bones. This is known as the resorptive pits, which are acidic. These are the acidic zones which are created at the ruffled borders of the osteoclast, followed by the resorption of the matrix by acid hydrolysis. That is, within the bones, normally within the bones, there will be a cycling of the resorption and bone formation. How the resorption happens? The osteoclast cells helps in the bone resorption. These osteoclast cells are mainly activated by the osteoblast cells itself, and then these osteoclast cells come into contact with the resorptive pit, mineralized matrix. Within this resorptive pit, there are acid hydrolysis and acidic pit, and within this, there will be less demineralization and resorption of the bone happens. Now, these bisphosphonates, when we are giving these bisphosphonates, they localize in this acidic zone. They are more tendency to be localized within this acidic zones, that is within these resorptive pits, due to a high affinity to calcium ions. So they have high affinity to calcium ions, they have high affinity to the acidic environment, they comes to the resorptive pits and ultimately covers it. Calcium ions released from the bone surfaces due to high acidity usually happens. Bisphosphonate also released. So ultimately they are internalized into osteoclast by endocytosis. So more and more bisphosphonates are internalized within these osteoclast cells that are on the verge of creating the resorption of the bones when we are giving the this bisphosphonate. So ultimately that results in accelerated apoptosis of the osteoclasts, reducing their numbers. So the osteoclast numbers are accelerated, reduced. So there will be less osteoclast cells for resorption of the bones, and also disruption of the cytoskeleton of the ruffled border of the osteoclast, because this ruffled border is needed for their attachment in the acidic pit with the mineraloid matrix of the bones. So bisphosphonate, when we are giving this bisphosphonate, comes through the blood near the bones, and within the bones there are osteoclast cells. These osteoclast cells forms the pits, resorptive pits, acidic environment. They starts resorption of the bones. Now this bisphosphonate comes and attaches with these bone surfaces with the osteoclast cells because of their higher affinity to the calcium ion as well as the acidic environment. they are internalized within the osteoclast cells. All this leads to more apoptosis of these osteoclast cells, so that less osteoclast cells will be available for the resorption of the bones. The ruffled border will be again disorganized, so the osteoclast cells, the few those are present, cannot interact with the mineraloid matrix, so that there will be less resorption. So ultimate result is the anti-resorption, that is resorption of the bone is less. So all oral bisphosphonates are poorly absorbed. They are very poorly absorbed from the intestine and have limited, very limited bioavailability when they are given by the oral route, like Alendronate, Zoledronate, only 1 to 6%. This drug should be administered with a full glass of water following an overnight fast and at least 30 minutes before breakfast. So how it is to be administered, the oral bisphosphonates? So these have not been used widely in children or adolescents because of uncertainty of the long-term effects of the bisphosphonates on the growing skeleton, because they are attaching with these osteoclast cells as well as the bones for a long period of time. So in case of the children, since they are growing, the bones are growing, so that needs continuous remodeling. We don't know, even if there is osteoporosis, what is the long-term effect of the bisphosphonate. That's why it is less or not used in case of the children. Bisphosphonates are excreted again primarily by the kidneys and are not recommended for patients with chronic kidney disease where the creatinine clearance is less than 30. So in chronic kidney disease, those patients on dialysis, we should not use the bisphosphonate therapy. So where it is used? Now it is the first line therapy for the osteoporosis. All cases of the osteoporosis prevention as well as the treatment. Again the Paget's disease, similar to the previous ones, because in the Paget's disease there will be honeycomb like bone architecture. They arrest the osteolytic lesions, reduce bone pain and improve secondary symptoms. All these are used. But we can combine this with the calcitonin. Already we have seen in the calcitonin is the mainly used in case of the Paget's disease of the bone. So we can combine this bisphosphonate along with the calcitonin. Hypercalcemia of the malignancy like that of the calcitonin, we can also use the bisphosphonate and some osteolytic bony metastasis. So these are similar to that of the calcitonin. So etidronate very lesser used nowadays. Pamidronate usually intravenously used in case of the Paget's disease and hypercalcemia. Alendronate, these are very commonly used nowadays. Alendronate is available in different doses of the oral forms, 5 to 70. Prevention as well as the treatment of the osteoporosis in men and women. How it is to be given, I will read this in the letter. Zoledronate is similar to Alendronate, but it is more potent. Again, it is used in osteoporosis and Paget's disease. And this Zoledronate or zoledronic acid, it is parentally effective, highly potent. Usually it is given once in 6 monthly or once in 12 monthly. That is once in year or once in 6 monthly injection is given with this zoledronic acid. Proliferation of the bony metastasis of the prostate and breast cancer cells are suppressed, can be infused in 15 minutes and cytokine release can lead to flu-like symptoms with zoledronic acid itself. So this zoledronate or zoledronic acid is approximately 5,000 to 10,000 times more potent than the first generation bisphosphonates. It is usually used once in 6 monthly or once in yearly. It is used. Okay. So now coming to the adverse effects of the bisphosphonates. So oral bisphosphonates, the main problems of the oral bisphosphonate is they causes different types of the gastrointestinal symptoms. The most common is the different types of the esophagitis, esophageal irritation, gastric ulceration. All these problems can happen. So you can see nausea, vomiting, diarrhea, constipation, all this can happen. So to minimize this gastrointestinal inflammation and ulcer, when we are using the bisphosphonate, the patient is to be instructed thoroughly how to take the bisphosphonate drug. So this is also very important. So when you are prescribing the bisphosphonate, the patient have to be told what is the method of intake of the bisphosphonate, particularly the oral tablets. Apart from this, there will be also bisphosphonate related osteonecrosis of the jaw, also known as the phossy jaw. So this is also severe adverse effect of the bisphosphonate, but it is rare. Osteonecrosis of the jaw. Initial parenteral infusion of these bisphosphonates also can lead to flu-like symptoms since they can cause the cytokine release. Zoledronate or zoledronic acid can cause severe hypocalcemia and has been associated with renal toxicity, deterioration of the renal function and potential renal failure. So all this can happen with the bisphosphonates. So of this you can see the bisphosphonate related osteonecrosis of the jaw. This is the typical of the bisphosphonates, but it is rare, but it is very dangerous. So how we have to instruct the patients when taking the bisphosphonate? First you have to tell these bisphosphonates are minimally absorbed, only 1 to 6% is absorbed. Okay. Now this bisphosphonate, when it is given, this bisphosphonate can cause severe esophageal and gastric irritation and ulcer. That's why this bisphosphonate tablet is to be taken in the morning in empty stomach. Minimal 12-hour empty stomach is needed. The patient have to keep him or her upright and to take with full glass of water, and then again another glass is to be followed after. Okay. So tablets must be swallowed whole. It should not be crushed or it should not be chewed. With a full glass of water on an empty stomach at least 30 to 60 minutes before food. The food have to be taken minimum 30 minutes to 60 minutes after, while standing or sitting upright. Okay, while standing or sitting upright. Patients must not lie down for 30 minutes after administration of these oral bisphosphonates. Like most commonly we are using the Alendronate or Zoledronate, or 1 hour after the imandronic acid, and they must not be taken at bedtime or before rising. Patients should be advised to stop the bisphosphonate tablet and seek medical attention if they develop any signs of the esophageal irritation, because it is very common if the patient will not take these bisphosphonate tablets properly. So it is clear, it is very important. So bisphosphonate, why these are? Because there is severe esophageal and gastric irritation and ulcer can develop if these are not maintained. So this is the instruction have to be given to the patients when they are taking bisphosphonate tablet. What tablet? Usually the Alendronate or Zoledronate tablets are given for the treatment of most commonly postmenopausal osteoporosis or osteoporosis in case of the elderly. Apart from this, it can be used in some hypercalcemic states, it can be used in Paget's disease, it can be used in some metabolic rickets. Okay. Now the osteoporosis, I have already discussed time and again what is osteoporosis and what are the different types of the osteoporosis. So again, so basically this is a systemic skeletal disease, low bone mass, microarchitectural deterioration, increased bone fragility and increased fracture. Primary and secondary, primary most commonly postmenopausal and age related means senility. Postmenopausal means postmenopausal because estrogen also helps in the bone growth and bone remodeling. So when there is sudden fall of the estrogen, in case of the postmenopausal women, there will be most chances of the osteoporosis. Similarly, osteoporosis also seen secondarily in case of the males in hypogonadal males, hypogonadism, that is the testosterone level is less secreted or less due to some other reason, less action. So again, the testosterone as well as the estrogen both are needed for the normal bone growth and development. So ultimately, if these two are deficient, there will be more chances of the osteoporosis. So these are the different diseases that can cause secondary osteoporosis. Like there may be some acromegaly, Addison's disease, amyloidosis, anorexia, COPD, hemochromatosis, hyperparathyroidism, lymphoma, leukemia, malabsorptive state, multiple myeloma, multiple sclerosis, rheumatoid arthritis, sarcoidosis, severe liver disease like primary biliary cirrhosis, thalassemia, thyrotoxicosis. So there are different types of the diseases that mainly leads to secondary osteoporosis. Okay, so both primary and secondary can develop, and we have to treat it more or less in the similar fashion. So there are some drugs that cause osteoporosis. Already I have said that the corticosteroids or glucocorticoids is the most common drug that you will encounter that can cause the osteoporosis. Apart from this, some aluminum mainly that can be present in the antacids, anticonvulsant drugs, excessive thyroxine, that is over replacement of the thyroid hormones in case of the hypothyroidism. GnRH agonist, already you have read about this. Heparin, in the heparin class, you can remember one of the adverse effect of the heparin is the osteoporosis. Lithium, again lithium that is used in case of the bipolar disorder. Again the adverse effect of the lithium is the osteoporosis. So if these are used in a high doses for a long period of time, osteoporosis can develop. So bone physiology, already I am discussing about this, that is the bone remodeling. So there will be cycle, osteoblast cell, osteoclast cell, osteocyte cell. Osteocyte cells control the osteoblast and osteoclast. Osteoclast causes bone resorption, osteoblast causes bone formation. Usually it is balanced, but if it is disbalanced, there will be osteoporosis. So bone remodeling units, these bone remodeling units are basically formed within these resorptive pits. Okay. So ultimately you can see osteoblasts produce the osteoprotectin, so which acts as a decoy ligand that inhibits the osteoclast production by competing effectively with RANK ligand for binding to RANK. So within this osteoclast precursor cells, there are RANK, receptor activated nuclear receptor kappa beta. Okay. So these are ligand. RANK ligand is present on the osteoclast cells, and these osteoclast cells, this RANK ligand, within the osteoblast there are RANK ligand. This RANK ligand attaches with the RANK receptors on the osteoclast cells. When this attachment happens, there will be activation of the osteoclast cells, so that there will be more resorption of the bones. Usually there are osteoprotectin. These are the decoy ligand. So when we do not need the bone resorption, osteoprotectin usually attaches with this, and there will be no activation of the osteoclast cells. When we need the bone resorption, the osteoprotectin will be removed, the osteoblast cells comes near the osteoclast cells, and then there will be binding of the RANK with the RANK ligand. Osteoclast cells are activated, differentiated, osteoclast cells form the resorptive pits, acidic environment, resorption happens, and then if it is normal, again the bone formation by the osteoblast cells happens. Okay. So you can see this is the bone remodeling unit. Osteoclast precursor, resorption by the osteoclast, formation by the osteoblast cells. So there will be resting stage of the bones, then activation of the bones, first resorption happens, then formation happens. It usually takes 2 to 4 weeks. So after the bone formation, adequate mineralization is needed for the normal bone. So it usually takes 3 to 4 months. So after the bone formation, there will be secondary mineralization. Mineralization will be continued for the months, and ultimately remodeling is completed. Then again it comes to the resting state, but again after some months or years, if it is damaged or if in some ways, again the cycle is repeated. This is the normal person. This happens normally in all of us. Okay. But what happens in the osteoporosis, when the resorption becomes more than the bone formation, or the other way around? Already I have discussed. So you can see this is the normal bone remodeling unit, and there will be more remodeling unit. There will be more resorption pits are developed. So the balance will be problematic, because there will be some pits developed that weaken bone due to some primary cause or due to some secondary cause. So ultimately there will be more bone resorption, but the bone formation is not at the same rate as that of the bone resorption. Okay. So this is the osteoclast cells. So ultimately inhibition of the resorption and osteoblast cells, stimulation of the formation. So these two are the main goal for the osteoporosis treatment. Already we have seen. So if we want to treat or if we want to prevent the osteoporosis, ultimately either we have to decrease the resorption of the bones or we have to increase the formation of the bones. Okay. So there are some osteoanabolic agents, that is these are mainly helps in bone formation, and some are mainly anti-resorptive agents, that is they mainly causes decrease in the bone resorption. So you can see this forms new bone, this suppresses the bone resorption. So basically it causes the increased osteoblastic activity, it causes the decreased osteoclastic activity. So the anabolic agents accelerates the turnover of the bones, and the anti-resorptive agents causes the slow turnover of the bones. Since ultimately the resorption is decreased, the cycle will also be slowed. Okay. So ultimately there will be new bone formation, bone volume is increased, and anti-resorptive agents mainly helps in increased mineralization of the existing bone. Since the bone turnover becomes slow, the mineralization will be completed if the patient is replete with the calcium and vitamin D. So the bone mineralization will be more, the microarchitecture will be more strengthened with the anti-resorptive agents. So you can see both these two agents can be used, but they mainly act in different ways. So anabolic agents or osteoanabolic agents mainly causes increased osteoblastic activity. They causes more new bone formation, bone volume is increased. And anti-resorptive agents, decrease the bone turnover, they decrease the resorption of the bone, they causes more increased mineralization of the bones and the microarchitecture of the bone is improved. So these are the examples of the anabolic agents like teriparatide, fluoride and androgens hormones. And these are the examples of the anti-resorptive agents: bisphosphonate, calcitonin, estrogen replacement therapy, selective estrogen receptor modulator. We will discuss about this in the female sex hormones chapters also. Calcium, vitamin D, thiazides, etc. And there is another drug like strontium granulate that have some dual type of actions, but it is lesser used nowadays. Thiazide diuretic, you already read about the diuretic, thiazide ones. Basically, they also reduce the urinary calcium excretion and constrain bone loss in patients with hypercalciuria. So, in those patients, if we need those patients with osteoporosis, if we need the diuretic use, we can use the thiazide diuretic because they help in the osteoporotic cause. Strontium granulate is basically a ranelic acid salt of the strontium. They are called the dual action bone agents because they have some anabolic actions as well as the anti-resorptive action. So they increase the collagen and non-collagen protein synthesis, enhances pre-osteoblast differentiation and decrease osteoclast function. But the problem is the thromboembolism. That's why it is less used nowadays. But remember, dual action bone agent, that is both actions is present for the strontium granulate. Fluoride, again, this increases the bone volume and trabecular bone mineral density by increasing the osteoblastic activity. Sustained release fluoride is associated with lower blood fluoride level, but they have shown to favorable effect on fracture incidence. Again, it is used on the third line agent or fourth line agent if the patient will not respond to standard therapies. Now coming to the Denosumab. Denosumab is a newer agent which was approved long back in the 2010. This is basically a monoclonal antibody. So it inhibits the RANK ligand. Already we have seen the RANK and the RANK ligand that is needed for the activation of the osteoclast. So human monoclonal antibody, it inhibits the RANK ligand which inhibits the osteoclast activation and survival. So basically RANK ligand binds to its receptor RANK, already we have seen, on the surface of the precursor and mature osteoclast and stimulates these cells to mature and resorb bone. So osteoprotectin is the natural decoy ligand if we need to block this. So this is the physiological inhibitor of the RANK ligand. This Denosumab is a human monoclonal antibody that binds with high affinity to RANK ligand, mimicking the effect of this osteoprotectin, okay, and thereby reducing the binding of the RANK ligand to RANK. So ultimately that blocks the osteoclast formation and activation, increases the bone mineral density, decreases the bone turnover. So you can see already I have discussed, again I am telling that osteoclasts causes the bone resorption, and this bone resorption happens due to the activation by the osteoblast cells. The osteoblast cells contains the RANK ligand and the osteoclast cells contains the RANK. RANK is basically a receptor. When the osteoblast cells comes near the osteoclast cells, RANK ligand binds with the RANK, the osteoclast cells are activated and bone resorption happens. Physiologically, when we do not need the bone resorption, there are physiological antagonists is the osteoprotectin. Osteoprotectin is a protein that is present in our plasma in a minute amount. This osteoprotectin binds with the RANK that is present on the osteoclast cells, so that the osteoblast cells cannot bind with this, okay. So that's why the osteoclastic activation will not happen. Now in case of the osteoporosis, there will be more bone resorption, so we have to prevent the bone resorption. Now we need an agent that mimics like the osteoprotectin. So basically we are giving a monoclonal antibody that acts like the osteoprotectin, that is this Denosumab binds with the RANK, that is the receptor activated nuclear kappa beta that is present on the osteoclast cells. So when they are bound to this, the osteoblast cells that contain the RANK ligand that cannot bind with the osteoclast cells, so that there will be no osteoclastic activation, no resorption of the bones. That's how the Denosumab acts. So it is clear, that's how it acts. Denosumab, monoclonal antibody. Next is another protein is the Sclerostin. Sclerostin is expressed by the SOST gene in osteocytes. So basically osteocytes, they also contain the osteoblast and osteoclast cells. they contain some sclerostin protein that respond to mechanical stress applied to the skeleton and appear to play an important role in the regulation of the bone remodeling. Okay. When sclerostin again binds to receptors on the cell surface of the osteoblast cells, a downstream cascade of the intracellular signaling is initiated with the ultimate effect of inhibiting osteoblastic bone formation. So basically sclerostin activation means osteoblastic bone formation is inhibited. So this is another normally present. Ultimately all this maintains a balance in the bone remodeling. Okay. So you can see this is the sclerostin. You can see mesenchymal stem cells or osteoprogenitor cells from these osteoblast cells are formed. And again some pro-osteoclast cells are formed. So it is clear. Now sclerostin can block these osteoblast cells. So they causes reduced mineralization. They also inhibit the osteoblast differentiation. And in the other hand, also RANK ligand that also causes the activation of the sclerostin. So ultimately this sclerostin leads to less osteoblastic action. So less bone turnover. Okay, it is clear. So you can see, so sclerostin ultimately this is the blockade sign. So they block the osteoblast bone formation and osteoclast bone resorption will be more when there will be more expression of the sclerostin. Okay. Now again, like that of the previous, we can develop an antibody that can block the sclerostin. Okay. So this is a monoclonal antibody that can block the sclerostin. So if we are blocking the sclerostin, the blockage of the osteoblastic bone growth will be less. The osteoclastic bone resorption again it will be less. Okay. So this is the known as the Romosozumab. This is the newest one. That is also one of the most potent agent that can be used for the management of the osteoporosis. But remember this Denosumab or the Romosozumab, these are costly. That's why. So Romosozumab is a sclerostin inhibitor. So sclerostin inhibitor. Okay. Denosumab, what is Denosumab? Denosumab is a osteoprotein mimic. That is Denosumab basically attaches with the RANK on the osteoclast cells and inhibits osteoclastic activation. Romosozumab is separate. Romosozumab is a sclerostin inhibitor. So ultimately it inhibits the sclerostin and again it inhibits the decreased osteoblastic action. So the Denosumab mainly acts on the osteoclast, Romosozumab mainly acts on the osteoblast. So it is clear. So used in the treatment of the osteoporosis, it significantly and rapidly increases the bone mineral density in both the lumbar spine, total hip, trabecular, cortical bone, etc., etc. It shows better results than other treatment. It is very potent, very efficacious drug, Romosozumab. It may increase the risk of myocardial infarction and stroke. This is the only drawback. That's why we have to check the cardiac function. In case of the Romosozumab used, we have to check mainly the cardiac function. In case of the Denosumab, we have to check mainly the kidney function. Glucocorticoid-induced osteoporosis. Already time and again I am saying that glucocorticoid most commonly used for a long period of time in different diseases and that can also lead to severe osteoporosis. Because it inhibits the osteoblast function and increase osteoblast apoptosis, it stimulates bone resorption, impairs the absorption of the calcium across the intestine, increase urinary calcium loss, induction of the some degree of the secondary hyperparathyroidism, reduction of the adrenal androgens because the androgens are also needed for the good bone growth. Testicular secretion of the estrogen androgens are diminished, induction of the glucocorticoid myopathy. So you can see there are several mechanisms by which glucocorticoid, long-term high-dose glucocorticoid may cause the osteoporosis. Usually prednisolone 7.5 milligram or its equivalent dose in other glucocorticoids, if it is used for months after months, that can lead to osteoporosis. So the treatment of this glucocorticoid-induced osteoporosis, again bisphosphonate is the first line or main treatment. Otherwise, we can use the different types of the hormone trials, calcitonin, thiazide, and again lastly the parathyroid hormone or teriparatide we can also use. So when there is osteoporosis, if there is some high risk of fractures, in case of the spine, we should use firstly the teriparatide because in case of the spines we need more bone growth. Teriparatide is an anabolic agent. Already we have seen in the previous class, parathyroid analogs. Anti-disruptive therapy, is to be followed after the teriparatide. That is, first we have to give some osteoanabolic therapy and then we have to give some anti-disruptive therapy. But apart from this, in case of the other osteoporosis in other bones, we can use the bisphosphonates first, that is the anti-resorptive therapy first, and if it is not controlled, then we can give some anabolic therapy or osteoanabolic therapy. Zoledronic acid we can use 4 to 5 milligram yearly, 3 years we have to reassess. Denosumab we can use the combinations or one after another. Oral alendronate we can use. If there is low risk of the fractures, we can start with the oral alendronate or oral bisphosphonate. And again, the most important thing, the patient have to be told about the instructions how to take the oral bisphosphonate tablets. Zoledronate or zoledronic acid, remember, it's a long T-half. Usually it is given 6 monthly or 1 yearly. Denosumab again it is given 60 milligram every 6 monthly. Denosumab is given subcutaneous injections. Again it is given 6 monthly or 1 yearly. Prevention of the osteoporosis, we need, apart from this therapy, regular resistant training, resistant exercise, aerobic exercise, this is needed. The foods, nutrition therapy is needed, that is replete with the adequate amount of the calcium and vitamin D. Elderly, increased dietary calcium and vitamin D supplement is often required. Adequate dietary calcium is to be taken for the children. Timely administration of the estrogen, because postmenopausal osteoporosis is very common. So, estrogen replacement therapy we can give. Prevention or correction of the hypogonadism. Hypogonadism can happen in case of the males, that leads to decreased androgen synthesis, that also leads to osteoporosis. Okay. So, this is about the osteoporosis. Apart from this, the two things that we will discuss in the other class is the estrogen and the estrogen replacement therapy, as well as the selective estrogen receptor modulator. So, I am just giving just 1 or 2 lines. Since the postmenopausal osteoporosis, we can use the hormone replacement therapy by replacing the estrogen, or we can use some selective estrogen receptor modulator. The selective estrogen receptor modulator means that have some agonistic activity in some receptors, antagonistic activity in some other receptors. So, this ACRM, most commonly raloxifene can also be used for the management of the postmenopausal osteoporosis. So, this estrogen as well as this ACRM, we will discuss this in the female sex hormones classes. So, thank you. This is all about the osteoporosis and the drugs that are needed for maintaining the calcium and vitamin D homeostasis. Thank you.